time is precious, it can be very useful after for the patient. I think so.
I'm sure you're right. I think dry lab, I think it's very important to try the
Yes.
dry lab. It definitely, as you mentioned about suturing, mastering the suturing in a small space. I think you need to have it in a dry lab before indulging on the patient himself. Right.
I definitely agree with you.
Thank you.
Please, Nafis, you can present Dr. Professor Laurent Storme.
Yes, of course. Okay, Professor Laurent Storme, Department of Neonatology from France. Okay, Dr. Laurent is the Professor of Pediatrics and Head of the Department of Neonatology at University Hospital of Lille, France. He is the coordinator of French Reference Center for the Rare Disease Congenital Diaphragmatic Hernia since 2018. Okay, Dr. Laurent, I'm gonna stop sharing this, okay? Can you share your own screen?
Oh, yes, thank you for the presentation. Hi. Hi,
Hi.
everybody. Can I share my slides?
Yes, yes. Just at the bottom of your screen, yes, the screen, yes, the green bottom is just, yes, share screen.
Could you please let me know how much time?
Yes, we can see your slides. Yes, it's great.
But how much time, what is the duration of my presentation? Because I have many slides, but I don't know if I need to shorten.
It's not
Okay, there's
not a problem.
no one after you, so you are the last presentation of the day, so you have time. Yes.
Okay, so thank you. I am happy to speak about this problem in CDH infants. Are there reliable prognosis factor? And the response is yes, but there are some major problem that I would like to speak. So in CDH, there is a defect in the diaphragm, and because of that, part of the abdominal organ moved towards the cavity, thoracic cavity, that may impair lung growth. In particular, when the liver is inside the cavity, and I wonder to say that liver up is a major prognostic factor, because a liver is not a compressible organ. So when the liver is up, it clearly impair and alter lung growth. And the main problem in CDH is related to associated pulmonary hypoplasia. So in CDH, the lung volume is decreased, and the main problem with that is number of vessels is also decreased. So there is less vessel for that may impair pulmonary blood flow. And the second problem in CDH is the fact that the pulmonary vessels are abnormal. There is a decrease in vasodilator response to vasodilator. For instance, there is a decrease in oxygen response. And moreover, the vascular wall is thicker than normal. Both pulmonary hypoplasia and abnormal vascular reactivity and decreased vasodilation to vasodilator stimuli cause pulmonary hypertension. And pulmonary hypertension is the main cause of death in CDH. You know that at birth, the pulmonary vessels need to dilate. Here is the fetal circulation, and during the fetal circulation in the fetus, pulmonary vessels are vasoconstricted. Therefore, the white ventricular outflow cannot go through the lungs, but is directed towards the descending aorta across the ductus arteriosus. And in fact, both heart, left and right, contributes to systemic blood flow. Left and right heart perfuse the tissue. At birth, because of alveolar and lung ventilation, because of increase in oxygen tension, pulmonary vascular resistance decreases steadily after birth, and therefore the pulmonary blood flow increases. And the circulation becomes in series, that is to say, the left pulmonary blood flow, only the left pulmonary blood flow contributes to systemic blood flow. So at birth, pulmonary vessels needs to dilate and pulmonary vascular resistance need to decrease. In CDH, because of lung hypoplasia, because of low pulmonary vessels, because of abnormal vascular reactivity and higher and thicker wall of the pulmonary vessels, there is a major failure of the cardiorespiratory adaptation at birth. That means that the pulmonary vascular resistance remains elevated. I can summarize here in this electrical schematic representation of what occurs at birth. Here is the right heart. Here is the pulmonary vessels. Here is the pulmonary vascular resistance, the pulmonary venous return, the left heart, the aorta, the systemic blood flow that perfuse the tissue, and the venous return to the right heart. And here there is a connection, ductus arteriosus connect pulmonary artery and aorta. In CDH, pulmonary vascular resistance remains elevated at birth. And the main problem is that the pulmonary blood flow is very low and remains very low. This has a major impact on systemic blood flow. I just come back. You see that the left heart, if the pulmonary blood flow is lower, that is to say that the pulmonary venous, the pulmonary venous return is very low, and the preload of the left heart is decreased, and the left ventricular output is very low. During that time, the only way to sustain systemic blood flow is through the right heart, across the ductus arteriosus. And in that condition, in CDH infants, the infants need to have a large ductus arteriosus for systemic blood flow to be sustained by the right heart, because the pulmonary blood flow is too low to preload the left heart. It's very important pathophysiologic description of what occurs in CDH at birth. The second problem with lung hypoplasia, especially in severe CDH, is a very poor tolerance of the lungs to over distension. The lungs also are very sensitive to barotrauma, as we can observe that in very preterm babies is similar problem. The lungs are prone to barotrauma. There is also poor tolerance to lung compression. For instance, after surgery, because of chylothorax, that may impair clearly ventilation. Finally, how is the circulation during the first hours, the first days, or sometimes the first weeks after birth in CDH infants? The pulmonary the pulmonary vessels remains vasoconstricted, and therefore, as during the fetal life, the right ventricular output contributes to systemic blood flow by crossing the ductus arteriosus, and therefore venous blood from the right heart induce a desaturation of the postductal area, and in CDH infants, preductal saturation is higher than postductal saturation. What is a consequence of such type of circulation? Does it impact oxygenation? And the response is no, because oxygen delivery, that is the amount of oxygen delivered to the tissue, is directly proportional to aortic blood flow, to hemoglobin level, and to oxygen saturation. Because of the contamination of the aorta by venous blood, this postductal saturation is decreased, but the aortic blood flow is increased. Aortic blood flow receive blood from both left ventricle and right ventricle. So the aortic flow, the systemic blood flow that perfuse the tissue is increased and compensate for the decrease in saturation. So in that condition, there is no hypoxia, and tissular oxygenation is usually adequate for several days and sometimes for several weeks, despite very low postductal saturation. The condition for that is the fact that the ductus arteriosus may remain patent, because right as in utero, right ventricular output may have to sustain systemic blood flow to compensate for decrease in oxygen saturation. This point is very important to prevent excessive treatment in these babies. So during that period of time, during the period of cardiorespiratory adaptation at birth, that occur in 5-10 minutes in normal full-term newborn babies, in CDH infants, it can take several days or weeks to obtain. In that condition, pulmonary vascular resistance remains elevated, pulmonary pressure remains high, and part of the right ventricular blood flow is directed towards the descending aorta. And that is usual circulation we observe in CDH infants. But as long as the ductus arteriosus is widely patent, there is usually no hypoxia, no cardiac failure, and the tolerance is good for the babies. What is main medical management? I will not go through detailed management, since that's the topic of the talk, but we need to provide adequate oxygenation and decarbonization while avoiding a lung barotrauma. The lungs, once again, is very sensitive to barotrauma, as in preterm infants. We should provide adequate circulatory function through PPHN management. And we should also prevent respiratory and nutritional morbidities. So at birth, the babies are immediately intubated in the delivery room. We do not use face mask for ventilation, as you know. After intubation, we need to use a gentle ventilation to reduce barotrauma. We need to place a gastric tube to monitor vital function. And we need to set the ventilator to target preductal saturation from 85 to 95. But there is no recommendation for postductal saturation. Postductal saturation is usually very low. We don't need to want to normalize postductal saturation. It's not a problem to have low postductal saturation as long as ductus arteriosus is widely open and as long as the aortic blood flow is sustained by the right ventricle. And we need also to distinguish two types of persistent pulmonary hypertension in these babies. You see the usual form is this one. Ductus arteriosus is shunting from right to left, and at the level of the atrium, the blood usually goes from left atrium to right atrium. When we see that, it is very well tolerated to the babies. If the blood goes from left to right, that means that the pulmonary blood flow is enough to preload the left heart. So that means that the pulmonary blood flow is enough, and we have to respect this condition. The second form of PPHN is very severe, it's very rare and severe, and we see right to left shunting across the foramen ovale, and we need to use extensive and treatment and complex treatment to treat this form of PPHN. So when we treat and manage PPHN in CDH infants, we need to understand what kind of PPHN is it? Is it this form of PPHN or is it this form? For example, we should use echocardiography to distinguish this form of PPHN. And you see here in the ductus arteriosus, you see a bidirectional blood flow. That means with very low blood flow velocities. That means that the pulmonary pressure and aortic pressure are equal. That means that the ductus arteriosus is largely open. And we are in the first kind of PPHN. Is in that condition, it's well tolerated. And when the blood goes from right to left, it decreased the postductal saturation, but it's not a problem. So let's go back to the object of this presentation. In CDH, mortality and morbidities is quite high in mortality, range from, according centers, from 10 to 40%, and morbidities range from 40 to 60%. So about half of the babies have prolonged morbidities lung morbidities, chronic lung disease, pulmonary hypertension, and regarding nutrition, many of the babies have oral aversion, failure to thrive, growth retardation, and some have orthopedic complication. So how can we anticipate the prognosis in CDH infants during the fetal life? There is 4 main prognostic factors. Is the CDH isolated, or is it a syndromic CDH? What is the gestational age at birth? What is the size of the CDH? And what is the severity of the pulmonary hypoplasia? And indeed, most CDH are isolated. Some of the isolated CDH have also lung sequestration, congenital cystic adenoid malformation, may have also left ventricle hypoplasia, but it's not considered as a major prognostic factor. It doesn't change the prognostic of the CDH, even left ventricular hypoplasia. It's usually, it occurs during the first days and then the ventricle grow after birth. But CDH in 30% of cases is associated with other malformation, severe malformations or chromosomic diseases, trisomy 18, 13, Fryns syndrome, Pallister-Killian, and actually, definitely the prognosis is more related to the associated disease than the CDH prognosis. The side of the CDH, we know that the mortality is similar in white and left CDH. White CDH is relatively rare, only 15%. But the main problem in CDH is there is no way to assess the prognosis in white CDH. At least it's very difficult. There is no good predictors to assess outcome in white CDH. Gestational age at birth is also a prognosis factor, and you see here that the survival decrease in preterm babies. The main challenge for the obstetrician is to address the question of, can we assess the severity of the pulmonary hypoplasia? Once again, the pulmonary hypoplasia is the main cause of death after birth. And can we estimate the risk of pulmonary hypertension? The answer is yes, we can assess the lung volume either by using echography or by using MRI. Both techniques can assess the lung volume. The gold standard is MRI. It's possible to obtain the volume of the contralateral lung, but also the remaining lung of the ipsilateral lung. With echography, we cannot see usually the ipsilateral lung. So we can assess an estimate of the lung volume by using an index named lung over head ratio. The surface of the lung is expressed according to the surface of the head. To obtain an index, lung over head ratio observed on expected. This lung volume measurement either by echography or by MRI, is usually assessed at about 26, 28 weeks gestational age. And you see the results. Many studies has been published on these predictor factors. And you can see that when the liver is up, but only when the liver is up, for the reason I discussed before, the lung volume measured by MRI or LHR is a reliable indice of prognostic factor. You see, when the lung is hypoplastic, the survival may be very low, less than 5%, or between 20 to 30% in severe form of hypoplasia. Similar results is obtained with MRI lung measurement. Clearly, the survival is decreased in low pulmonary volume, but only when the liver is up, because the liver, when the liver is up, there is no possibility for the lung to grow between the period of measurements, 26 to 28 weeks gestational age, and birth. When the liver is down and remains in the abdominal cavity, there is a possibility for the lungs to grow during the fetal period after the measurement and assessment at the second trimesters. So the lung can grow during the third trimesters when the liver is done. It's explained why, when the liver is done, there is no reliable parameters to address the question of lung volume. So at the question, is it possible to prenatally assess the mortality? The response is yes. We can assess the vital risk in the fetus with CDH. There is consensual method for the obstetrician. The obstetrician are trained and regularly trained to do these measurements, and the method are clearly very standardized presently. For what is it useful to address the question during the fetal period of the postnatal prognosis? Is there an impact for the management? Once again, the response is yes. As we know that when the lung volume is very low, below 25% of observed unexpected, we can use antenatal therapy, whose name is fetoscopic endoluminal tracheal occlusion, FETO. A balloon can be placed by fetoscopy inside the trachea to occlude the trachea. As the lungs produce each day about 300 milliliters of fluid that cross the pulmonary airways, this lung fluid stay inside the lungs, that increase the pulmonary pressure and expand the lungs. And this expansion of the lungs induce a pulmonary growth and reduce the risk of pulmonary hypoplasia. This hypothesis has been confirmed in two large, very large clinical trials that has been published recently, that have clearly demonstrated now that a plug FETO technique improve the prognosis in severe form of CDH and should be used and proposed to parents, at least in severe form. The problem of this technique is that it increases the risk of prematurity that have also that is a side effect of the technique. The second interest of assessing the prognostic factor in CDH infants is that we can stratify the severity of the CDH disease, and it's required when we want to test new hypotheses, new treatment, new management. It's as the CDH is a very heterogeneous disease. Some babies have no symptom, and some baby died in the delivery room. So when we do an essay, a trial, we need to stratify for the severity of the disease. And prenatal assessment of lung volume is the best way to stratify the CDH patients for clinical trials. Just stop me if you want to ask a question. It's okay.
No. No,
So, what is there other interest of prenatal assessment of vital risk? Yes, we can use it for parental information. We can speak with the parents with the mortality, the risk of mortality, depending on the lung size and liver position. We know now clearly what is the risk according to the lung volume measurements by echography or by MRA. The true question is, do the parents need this kind of information? Perhaps. But the second thing I'd like to address with you is we need, if we use this kind of information for the parents, we need to be very cautious, and we need to be aware of the problem of using this kind of table and number to inform the parents. Here you see the mortality rate at 28 days after birth, according the lung to head ratio, no, according to lung volume. And you see that when, as expected, when the lung volume is decreasing, there is an increasing in mortality. But what I wanted to highlight on this figure is that the wide range of the standard error of the measurements, of the mean measurements. That means, and it's related to the mortality, it's a different mortality rate dependent of the centers. Most of these studies has been done by pooling the results of different centers with different mortality rate, and we have a mean. But what is the meaning of this mean? In some center, you see here, with 10% of the volume, in some centers, the mortality rate is 30%. And in some other centers is 80% survival. Mortality rate is 80%. So there is a wide, very large range of standard error in the measurements. It clearly depends on the experience of the centers. Similar results have been published 15 years ago You see here the mortality survival according to the long volume, and you see the results of different centers, and you see in the black centers, it's from the city of Rennes, the mortality survival rate is very high, independent of the long volume, and in other centers, mortality is high. So for one predictors, the results may be different center by center. What is the reason for that? Is the reason because it has been demonstrated that standardized treatment clearly improve survival in CDH infants, and the experience of the centers change also the results. Better results is observed in centers with caseloads above 6 patients per year. You see here, the when we compared the mortality at 28 days postnatally between centers in which there is standardized care or not, you see that the difference is very large. The second problem is that the mortality is changing with time. Here is Lille results. You see, in the late 80s, mortality was very high, and now it's about 20% mortality. And other centers also highlight such change in mortality rate with time. So what is true now will probably not be true in the future. So we have to be very cautious when using the number with the parents. There is no doubt that it's sure that the long volume is an indicator of vital risk in CDH, but the associated numbers may be used with caution. But finally, what is at stake for the parents? Do they need to have the precise mortality rate? Their need probably what is at stake for the parents? Probably for the parents, the more important question is what is the morbidity? What is the long-term outcome? What is the future? What could be the future of my baby? What can we say about that? We have no indicator of that. Why we have no indicator of that is that the morbidity we know now with many studies. Here is the result from the Lille cohort. You see that the morbidity is decreased over time. At 2 years, morbidity is largely significant, but decrease at 5 years and decrease again at 10 and 15 years. So we know that CDH babies have a difficult time for a few months, sometimes 1 year, even 2 years, but later babies recovered mostly of most of the problem. Here is a nutritional outcome. You see the goose curve. You see, as just stated, there is a progressive decrease, improving in the gross Z-score. Moreover, what is really at stake for the parents? Is it the listing of morbidities, or the question would be, the best question would be, what will be the health-related quality of life? What will be the quality of life of my baby later in life when we will be adult? Yes, more quality of life is dependent of the degree of morbidity, but you see that morbidity is more related to the resilience of the family. It has been published largely now. The quality of life is more dependent on the family support, the degree of the family support, than the degree of morbidity. So for physicians, we seek for prognostic factor for mortality, for morbidities, but we have no true good indicator of future quality of life, because it depends of many factors that are not accessible at that time during the antenatal period. And we know that the future, the quality of life of the future of the babies is more related to the resources we as healthcare provider, we can mobilize around the baby, personal resources, family resources, caregiver resources, and social resources, all the capabilities that may change the outcome of CDH babies. And if we want to respond to the parents' needs, it's better to provide empathy to the family, to provide alliance with the parents, and relational commitments with the parents. And we can say that the health-related quality of life for the infants, CDH infants and its family, is more dependent on the relationship between the parents and the healthcare providers. It has been, the quality of life has been assessed 15 years ago in CDH patients and compared to control. And you see that in this population, the duration of mechanical ventilation was 7 days, 21 days of hospitalization, 20% of recurrence, 20% scoliosis, 50% more digestive morbidities. You see, very similar of what we have observing now at the present time. Here is the results. The mean score, health-related quality of life was similar between control and CDH groups. And there is no correlation between the severity of the disease and the score. Despite we observe a number of low score that was higher in the CDH group, but mean score was similar. It's a good news at the adult age. And I'd like to finish this presentation by introducing one, I think it's a main risk of a search for perinatal assessment of vital risk. There is also a risk. When physician or staff, medical staff, obstetrician, pediatrician, nurses see this kind of table, what would be their engagement to use treatment when they saw so low a level of survival? Can it be possible that to know these results can change the quality of our management that may impair the results? And it's to say that there is a risk, a possible bias through self-fulfilling prophecy. If we think that the baby have no chance to survive, yes, there is a risk that we increase the risk of mortality. That has been demonstrated in a condition with at the limit of viability in preterm babies in France, by comparing two different cohorts. It has been highlighted. It has been also highlighted in adults with cerebral stroke. It has been also demonstrated in polymalformative syndrome. We don't know yet in CDH infants, but it's a possible bias that self-fulfilling prophecy can explain or sustain these results. I'd just like to finish this talk by using this slide that has been displayed 2 years ago at the last CDH Congress. Professor Keys from John Hopkins Houston finished his talk by saying that we need to believe they can survive if we want to improve the prognosis of babies with CDH. I think it's my last slide. Thank you for your attention.
Thank you. Thank you very much. Have you some question for the speaker, the brilliant speaker? No? Oh. Un commentaire, just a commentaire. The mortality in the very preterm infants is very high, and the prenatal diagnostic allow to reduce the care in postnatal life. Do you think that there is a choice with prenatal diagnosis? You choose to stop the life of the baby to not go to the birth, and is it a bias in the mortality with the choice in prenatal diagnostic?
Yes, I understand your question. It's a very, very good question. And I highlight this discussion on the self-fulfilling prophecy because of that. If we are sure that the results are very poor, yes, some centers may propose to stop the pregnancy. And it's a risk. If we stop the pregnancy, we, because of this problem of self-fulfilling prophecy, we will consider that when the lung volume is below threshold, we should stop the pregnancy. And by doing that, we will never know that it's possible to survive. As the discussion, the presentation in Houston, in USA, there is usually no interruption of pregnancy. So they know that it's possible to survive even when the lung volume is very low. I didn't show the results, but they have 80% survival when the lung volume is very, very low. In Europe, and some data, it's less than 5% or 15% survival. It's a problem. It's a problem.
Yes.
The survival depends on the management and the engagement we have for the babies. If we think that the baby, whatever we did, we can do, will die, we are not engaged. We will not engage this treatment. So we need to think that the baby can survive. If we want that the baby, if we want to increase the probability of survival.
It's
When I say that, I don't want to say that there is no need for assessing the lung volume in the prenatal life. It's very important to for the antenatal plug and fetal. It's sure. I just discuss the impact and consequence they can have in the postnatal management. We have to be very careful about that. But yes, I defend the idea that we need to address the question of the prognosis factor, but only to perform or not fetal. Or also the other interest is to stratify the risk factor for clinical trials. But it do not change. It do not. We should not change our postnatal management.
This is the reason that there is 20 years ago, before the choice in antenatal life, we had a very poor prognosis, vital prognosis of diaphragmatic hernia, and since we chose to childbirth the baby before the birth, you improve the prognosis of hernia in postnatal. It may be a bias. No?
I don't understand what you mean. You mean that before we stop the pregnancy? You mean it's what you mean?
Yes. If you stop the pregnancy when the form of hernia are bad, you improve the postnatal prognosis. If you don't stop the pregnancy in antenatal bad form, you don't improve the prognosis, the global prognosis.
Yes, I agree with you. I agree with you. It may explain why some of the difference centers by centers. Yes, I agree with you. If there is a lot of interruption of pregnancy in severe form, the results, the outcome will be better in these centers. I agree with you.
Just a very simple question. You didn't speak about nitric oxide. Is it because it's obvious, or is it because it's not interesting in this indication?
It's a very, very good question. May I go back to my slide to present to address this question if it's possible. It's a very good question. There is two forms of PPHN in CDH infants. In 3 on 4 case, it's this form of PPHN. In this form, pulmonary pressure is high, and there is a right to left shunting across the ductus arteriosus. But in that condition, preductal saturation is adequate, and postductal is decreased about 60–70%. But here is 90% in the preductal zone. It's because the left atrial pressure is enough to have a shunt from left to right. That is to say, the pulmonary blood flow is high enough to preload the left ventricle. In that condition, there is no need to use a nitric oxide, and there is now evidence that if we use nitric oxide in this kind of PPHN, we may, it has been demonstrated in meta-analysis, if we use inhaled nitric oxide in that condition, we increase the need for ECMO, probably because we will increase the pulmonary blood flow, that will increase pulmonary atrium pressure, left atrium pressure, that may have adverse effect in the lungs, that may cause edema, lung edema. And it should, inhaled nitric oxide should be limited in this particular form of PPHN, during which there is right to left shunting across the foramen oval. That is to say, it's because the left atrial pressure is very low, and if the left atrial pressure is low, it's because the pulmonary blood flow is not enough to preload the heart, the left heart. And in that condition, inhaled NO is not only is really required to improve and to increase the pulmonary blood flow. Here is not a problem of pulmonary blood flow. That condition is related. I did not discuss that before, but in many cases, the left heart is hypoplastic, and there is a risk to increase pulmonary blood flow when the left heart is hypoplastic. I don't know if it's clear. It's similar. It would be similar to. We need to think here in that condition. The management should be very similar to hypoplastic left heart. In hypoplastic left heart, there is high pulmonary pressure, but we don't use inhaled nitric oxide. And inhaled nitric oxide is contraindicated in left pulmonary, left heart hypoplasia. So we should reserve nitric oxide in this condition.
I understand. Thank you.
So if there are no questions, I have to thank very much all the speakers and all the speech or the talk were very, very good, very exceptional. But in spite of 50,000 contacts by email and publicity of this manifestation, we had only a few participants. I think that the people don't know what he wants. He wants to know. I am very disappointed for all the speakers, all the brilliant speakers, but I promise that if possible, we renew this Congress with Presidential Congress in the near future when the pandemic is not so bad, and to have more presential participant. I thank you very much. And tomorrow there is a very brilliant speaker also. You can begin at 9 o'clock tomorrow morning, and there is maybe a perinatal subject, an obstetrical subject, very interesting for perinatality network, and I hope that you have spent a good day with us. Thank you very much.
Goodbye, Claude. Thank you.
Thank you.
Dr. Claude.
Thank you.
Thank you, Dr. Claude. Thank you, everyone. Thank you, Nafizi.
Thank you. Thank you to Confrontiers also, to Nafis and Krishna and Alice, and thank you very much. Tomorrow morning.
Thank
Okay.
you, Dr. Claude. It's always a pleasure meeting you.
See you tomorrow. Yeah. Thank you.
Bonsoir, everyone.
Bonsoir, Claude. Est-ce que vous m'entendez-vous?
Oui, très bien.
Oui, merci, merci. Je suis d'accord absolument avec vous parce que, in my opinion, according to my opinion, the contribution of the participant on has been very, very, very high. It's brilliant, brilliant. I have, with a lot of years of pediatric practice, I have learned a lot of new perspective, new view about severe pediatric problem, new and original. I thank you for your effort for keep this meeting, not only till the present, but for the projection for the future. I'll be always with you. Thank you very much indeed, Claude.
Merci beaucoup. Bonne soirée. À demain.
À demain, à demain.